Right, so we are going to start with this talk on case area targeting interventions to try and reduce the infection rate, the spread of cholera. So we'd like to give you an update on what has been done so far. Now, the case area targeting interventions are based on the early detection of cholera cases to trigger a quick response circumscribed to the high-risk radius around the cases, so as to slow down the epidemics. It's therefore a multiple direction intervention close to the cases, and other attempts have been carried out with the MSF or with UNICEF, and CATI works well. They've shown this, but what about its efficacy? Now, the CATI strategy, we think, is the most interesting at the start of an epidemic or at the end of the outbreak. Now, the CATI strategy used by MSF and Epicentre is designed by experts with a package for intervention. With the cholera vaccine in DRC, it involves 2 doses, the hygiene kit, the hygiene promotion, and chemoprophylaxis given only to the households with cholera cases, but also to households that are the closest. As it stands, there's limited evidence about CATI associated with vaccination, and this is why Epicenter decided to carry out a prospective observational study during CATI interventions in order to accompany the operations and assess feasibility of combining CATI and vaccination. And the aim was to assess the efficacy of this strategy. The study was designed in order to allow for easy adjustments to the variations in the CATI strategy, and Epicentre accompanied the teams in order to collect data and measure or count the number of secondary cases in each ring in order to measure efficacy and see the coverage of interventions and documenting resources. Now, let me show you the first results. We carried out CATI interventions in DRC as of April 2022 in North Kivu, more particularly in Goma, and it is completed by April 2023. The study team are currently consolidating the database so as to come up with the final results. However, since we implemented CATI, 118 rings were implemented in 5 sites in 4 provinces of DRC, as shown here on the map, and 4 MSF sections implemented this strategy. In the table, you can read the number of CATI rings included in the study for each site. Now, if you consider the number of households per ring, the global median is 69 households. There was some variability between rural and urban sites, like Bahimba and Baganga, which are peri-urban sites, for which the median was 36 households per ring. However, in Katuba, a densely populated site in High Katanga and the Lubumbashi city, the median figure was 176 households. If you combine all sites, the smallest ring had only 1, and the largest one 200 households. Now, with regard to the administrative vaccine coverage, the median figure is approximately 89%. We think it's a good coverage. However, you can find some variations across the sites.
Now, here we have the timeline for the various CATI interventions. the overall lead time between the beginning of the symptoms of primary cases triggering CATI was 2 days. It didn't vary much between sites, but when you look at the medium time lag until the beginning of the vaccination, it was a bit longer, 3.5 days. There was some variation between the sites. It was a major one in Mbuji, where in the eastern part we had some administrative constraint, which led to a lead time of more than 10 days. Lead time to distribute hygiene kits was highly variable and sometimes very long due to logistics issues and the availability of the kits. Also, health promotion activities often started at the very beginning of the CATI intervention, but it was extended until the end, over several weeks sometimes. For the study, we took into account the secondary cases with the beginning of the symptoms between day 2 and day 30 after the beginning of the symptoms of the primary cases and those positive to the rapid diagnostic test. We see here that for the majority of the sites, the 75th percentile of the number of secondary cases for the implemented rings were at 0 cases. It means in 3/4 of the rings we didn't have any secondary case, and the number of secondary cases went up to 9 for one particular ring in Katuba in the High Katanga province. Our first conclusions, first findings: a quick implementation of CATI is possible along with vaccination, because CATI can be initiated in 2 days and vaccination 3.5 days after the early primary case symptoms. We had a good administrative vaccination coverage for the first dose, so CATI along with vaccination do work well, as 75% of the rings we couldn't find any secondary case. We have high variability between sites, which reflects different contexts, but also it reflects the operational choices that were made by the various teams. And the analysis of the efficacy of CATI is still underway. Now, here is a recent situation in Goma, near the end of the study, near the site where MSF was doing CATI. The number of cases reported to the cholera treatment unit in Buhimba went from 12 cases to more than 140 cases per week, and MSF was no longer capable of doing systematic CATI, yet MSF continued to intervene by giving the vaccine as well as antibioprophylaxis to the household members. So any outbreak can grow quite quickly, and when an outbreak turns into an epidemic too quickly, CATI has its limitations. A smaller scale community response and a conventional response to cholera in the camps was the choice we made after that. Yet we recommend that if you get too many cases, you may switch your strategy. But sometimes CATI is not possible. You cannot roll out CATI under certain situations. It's good at the very beginning of an outbreak and also at the end of an outbreak. A few words about what will become of CATI in DRC. We have a discussion on how and through what approach CATI, along with vaccination, will be implemented in the future, by what actors. Can we have a reserve of vaccines dedicated to the CATI strategy, and maybe a CATI workshop to present the final results of the study and share MSF OC's experiences in DRC might be beneficial to determine a final strategy. Internationally, there is a trend to use CATI for several epidemics, and this by quite a big number of actors, and yet there is no guideline as to the strategy to use, or a sort of guideline that we'd like to be given to know how to roll out CATI. CATI can be a strategy to reach out to the people the most at risk and can also contribute to mitigate outbreaks and epidemics even before a larger scale response is organized. And this particular in a context where vaccines are quite limited. I will end this presentation by thanking warmly all the people who took part in implementing this CATI strategy, particularly the study team that worked in DRC, also all the operational teams of MSF and the support of Mali, the Ministry of Health of the Democratic Republic of Congo, the National Cholera Control Program, also extended vaccination programs and all the local authorities, as well as the Epicentre MSF co-investigators and the people of the ministry which contributed to the success of this study. Thank you very much.